It's time for the 3-question warm-up for GI-14. Let's get going. A patient with lung disease is found to have anti-glomerular basement membrane antibodies. What is the treatment? So first, you got to get the diagnosis. It's Goodpasture syndrome. And the treatment is plasmapheresis, maybe steroids, and even possibly immunosuppressants. Next, what are the components of the medical management of peripheral artery disease? Well, there's a lot of things. Big one, quit smoking. So smoking cessation, number one, you want to increase your exercise, you want to have good glucose control, you want to have a good diet, lose some weight, blood pressure control, and cilostazol is another medication you could potentially use. Next, what anatomic locations are options for immediate needle decompression of a tension pneumothorax? So you can use the second or third intercostal space in the mid-clavicular line, or you can use the fourth or fifth intercostal space in the mid-axillary line. All right, that's it for the warm-up. Let's get to that lecture now.
In this video, we're going to talk about the effects of alcohol on the liver, from alcoholic steatohepatitis all the way to cirrhosis and portal hypertension. Now, long-term alcohol abuse causes gradual progressive damage to the liver. The first thing you see is hepatic steatosis, which is fatty deposits in the liver. So here's a liver biopsy from a patient with steatosis. And these white areas are big fat droplets within the hepatocytes. So these aren't adipocytes or fat cells. This is just lipid that accumulates within the liver cells themselves. So this is hepatic steatosis. And early on, this is reversible. So drinkers start getting steatosis and fatty liver, but if they stop drinking, the liver can begin to heal itself. Now, with prolonged alcohol abuse, the steatosis turns into steatohepatitis, which means that there's fat and inflammation in the liver. So you also start to see some early necrosis. And at some point, this liver damage becomes irreversible, and the inflammation leads to fibrosis and scarring of the liver, which is cirrhosis. So this is a liver biopsy that shows cirrhosis. You've lost a lot of the normal architecture. And these lighter pink areas are the more or less normal hepatocytes, but the darker areas are the areas of inflammation and fibrosis. And all those purple cells are lymphocytes and inflammatory cells. Now this is a trichrome stain, where the collagen stain's blue. So again, the pink areas are these residual nodules of hepatocytes, but a lot of the hepatocytes have undergone necrosis and they've been replaced with all this blue collagen and fibrosis and scarring. There's also a disorder called non-alcoholic fatty liver disease, or NAFLD. So this is liver disease that looks exactly like that early reversible steatosis we see in drinkers, but it's seen in patients who don't have a significant alcohol history. So instead, NAFLD is associated with obesity and the metabolic syndrome. But just like alcoholic liver disease, NAFLD can potentially progress to steatohepatitis, which we call non-alcoholic steatohepatitis, or NASH. And this looks exactly like the early changes you see in the liver of a heavy drinker. And it can progress to cirrhosis and liver failure. So in some ways, obesity could be just as bad for the liver as alcohol abuse. So take a look at number 4 in the study guide. NASH is associated with obesity, diabetes, hyperlipidemia, and insulin resistance. And that insulin resistance leads to accumulation of fat and lipids in the liver. Now, one clue to the presence of NASH would be chronically elevated LFTs, so that's a misprint in your study guide, not just ALT, but also AST and also ALK-Phos. So if on your test they give you an overweight patient with chronically elevated LFTs who's not on a statin or some drug that could cause that, and the patient swears they don't drink, think about NASH. And what would the next step be in that patient? To make the diagnosis, you can image the liver, probably with an ultrasound. So you can identify fatty changes on ultrasound or on CT or with an MRI. Now, the gold standard is an MRS, a magnetic resonance spectroscopy. You can also see these changes in the biopsy as well. Then the treatment for NASH is, first of all, avoid all alcohol. Even though it wasn't alcohol that caused this, alcohol can certainly make it worse. Anybody who has evidence of liver disease should probably get off alcohol altogether. You want to counsel the patient to lose weight. You need to control their diabetes if they have it. And interestingly, TZDs like pioglitazone have been shown to improve LFTs and reduce some of the fatty change and the inflammation. Now, that's an off-label use, but how do TZDs work? By improving insulin resistance. Metformin may also be beneficial, but again, that's an off-label use. All right, enough of that non-alcoholic sidetrack. Let's get back to alcoholic liver disease. Patients may be asymptomatic for years and years and years with alcoholic liver disease. And then once they start having symptoms of cirrhosis, that means their liver is pretty far gone. Late in the disease, they can get some anorexia, some nausea and vomiting. They might have abdominal tenderness, ascites and splenomegaly as they start to develop portal hypertension as well. We're going to talk about the features of portal hypertension in a little bit. Lab work may show elevated ALT, AST and GGT early on, but once you become so cirrhotic that most of the hepatocytes have been damaged, those labs could be normal or even low, because when you don't have many hepatocytes left, there's no more AST and ALT to spill out into the blood. Now, in viral hepatitis, AST and ALT are usually equally high, but in alcohol-related liver disease, AST is higher than ALT by at least a 2-to-1 ratio. You might remember the phrase, a scotch and tonic, which spells out AST. That's going to help you remember that in alcoholic liver disease, the AST is more elevated than the ALT, usually at least twice as high as ALT. That's a pretty good clue clinically. So if you have a patient with an ALT of 200 and the AST is only 300, that's not likely to be due to alcohol. But if the ALT is 200 and the AST is 450, alcohol is one of the few things that will do that. Most toxins and other forms of liver injury will elevate AST and ALT equally, but with alcohol, the AST is at least twice as high as the ALT. Now, in addition to ALT and AST, these patients can have elevated alk phos and elevated bilirubin. And then also, when the liver is sick, it loses synthetic function. So these patients may have low albumin, they're not making clotting factors, they may become hypocoagulable, and you'll have a prolonged PT and PTT. The liver also makes triglycerides and LDL and HDL. So in liver disease, you might see low triglycerides and low LDL and low HDL. You could also see an increased white count. Now, how do we treat alcoholic liver disease? First and foremost, the patient needs to stop alcohol use. Thiamine, folate, and high caloric intake are also important, mainly to deal with the effects of the alcohol abuse, not so much for the liver. And then liver transplant is a consideration in patients who are able to stay off of alcohol. Now, how long does the patient need to be off alcohol before he or she is eligible for a liver transplant? You need to be off alcohol for at least 6 months. Next, let's talk specifically about cirrhosis. So lots of things can cause cirrhosis other than alcohol. Hepatitis B and hepatitis C can definitely lead to cirrhosis, but it's more common in hepatitis C. Bile duct obstruction and chronic cholestasis, including PBC and PSC, which we covered elsewhere. Then there are a variety of hepatic parenchymal diseases, which are also covered elsewhere. Things like hemochromatosis, Wilson disease, alpha-1 antitrypsin deficiency. We mentioned NASH, autoimmune hepatitis. So lots of different things can cause cirrhosis. But the two biggest ones in the U.S. are alcoholism and hepatitis C. Now, I like to divide the signs and symptoms of liver disease and cirrhosis into manifestations that come about because of liver failure or hepatocyte failure, and manifestations that come about because of portal hypertension. So most patients with cirrhosis will have symptoms of both liver failure and portal hypertension. So let's kind of separate these out. We're going to talk specifically about portal hypertension a little bit later on, but portal hypertension causes esophageal varices, which can lead to upper GI bleeding. It might cause a caput medusae, which is a mass of dilated vessels on the abdominal wall near the umbilicus. Portal hypertension can cause enlargement of the liver or hepatomegaly, and also splenomegaly because blood backs up into the spleen. Ascites is due to portal hypertension as well. We're going to talk about portal hypertension in detail in just a moment. But for right now, let's focus on the clinical manifestations of liver failure. So I like to think about liver failure in terms of the three main things that hepatocytes do. Hepatocytes conjugate bilirubin from the blood and excrete it in the bile. Hepatocytes synthesize proteins, and they metabolize toxins. So if the hepatocytes stop putting bilirubin into the bile, bilirubin is going to build up in the skin and into the eyes. You're going to see jaundice. If the hepatocytes aren't synthesizing proteins, you can have lots of problems. If they don't synthesize coagulation factors, you're going to get coagulopathy and elevated PT and PTT, and you might see some bleeding and bruising from that. If they don't synthesize albumin, you're going to have decreased ability to carry hormones and drugs that are normally bound to albumin. You can also have decreased osmotic pressure, keeping fluid in the vasculature. That fluid is going to weep out, and you're going to get peripheral edema. And that can also contribute to the ascites. And if the hepatocytes can't metabolize toxins, like ammonia, you can get something like hepatic encephalopathy with confusion and delirium and hypersomnia and even coma and death. Hepatic encephalopathy can also cause something called asteriscus or liver flap. We have the patient extend the arms and kind of extend the wrists, and then the hands will kind of flap because the patient can't maintain that wrist extension. Now, liver failure also alters sex hormone metabolism and causes increased conversion of estrone to estradiol. So with high estrogen, you might see testicular atrophy and gynecomastia in men, or you can see spider telangiectasias, which are little telangiectasias, usually on the chest. They have a little red spot in the center and then tiny vessels radiating out from the center, so they kind of look like legs on a spider. So these are called spider telangiectasias or spider angiomas, and high estrogen causes that. High estrogen also causes palmar erythema, so these patients can have redness on the palms of their hands. So those are the signs and symptoms of cirrhosis that are related to liver failure. Then there are also a few other signs and symptoms that either don't fit neatly into either portal hypertension or liver failure, or they're just sort of nonspecific. Patients can have weakness, they can have weight loss, they can have digital clubbing. No. We're talking about clubbing of the fingers, which we usually think about with hypoxemia and lung disease, but cirrhosis can cause it too. You can also see Dupuytren's contractures, which are contractures in the flexor tendons in the palm of the hand. Now, these are not always due to cirrhosis, but anytime you see these in an elderly patient or a middle-aged patient, you might do some imaging and some labs to look for evidence of cirrhosis. About a third of patients with alcoholic cirrhosis will also have Dupuytren's contractures. Now, just like we saw with alcohol-related disease, cirrhosis can cause elevated AST, elevated ALT, or these labs could be normal or even decreased as the cirrhosis gets more severe. You might see low albumin, anemia, low platelets, and prolonged PT and PTT. If you did a paracentesis, the ascites is going to be a transudate, so it's going to have low protein, and also a low white blood cell count in the fluid, but the glucose is normal in the fluid. We usually start imaging with an ultrasound, which is going to show a small nodular liver. This isn't ultrasound, obviously, but a gross image of a cirrhotic liver from an autopsy. So you can see that the liver is shrunken down because all that collagen, all that scarring kind of contracts down. You can also see that the surface of the liver is very nodular. It doesn't have that smooth, shiny, healthy appearance. So cirrhotic livers are relatively small and nodular. Now, cirrhosis is irreversible, but you can slow or even stop the progression of cirrhosis and prevent further liver damage. So the patient needs to stop all alcohol. Even with cirrhosis from something else, like hepatitis C or Wilson's disease or whatever, you still want to counsel these patients to avoid alcohol. You also want to avoid any other potential hepatotoxins, like acetaminophen. We give lactulose to treat hepatic encephalopathy. So what does lactulose do? Lactulose is a sugar that your body can't absorb, and it actually lowers the pH in the colon so that ammonia gets trapped in the gut and it can't be reabsorbed. So lactulose allows you to excrete the ammonia in the stool rather than reabsorbing it. And because we can't absorb lactulose, it's also going to cause an osmotic diarrhea. That's actually how you know you're giving enough lactulose. You sort of titrate the dose until the patient's having 3 soft stools every day. We also sometimes give the antibiotic rifaximin to treat encephalopathy. Now, why do we give rifaximin? Well, ammonia can be generated by enteric bacteria. So by killing off the gut bacteria, you can reduce ammonia levels and treat the hepatic encephalopathy. But lactulose is used a lot more often than rifaximin is. And then patients with severe cirrhosis may end up needing a liver transplant. You just got to make sure they're not still drinking so they don't end up damaging the new liver. Now let's talk about portal hypertension. Portal hypertension is high pressure in the portal vein. So imagine that your liver is a screen door and the blood is flowing to the liver from the portal vein. As long as the liver is healthy, the blood can flow through that screen door without any problem. But if you have cirrhosis and scarring of the liver, it's like somebody took a big handful of mud and threw it against the screen door. So all the little holes in the screen are plugged up and blood can't flow through anymore. So blood coming from the portal vein is going to get backed up and the portal pressure will rise. That's portal hypertension. Now, cirrhosis is one cause of portal hypertension, but it's not the only cause. There are prehepatic, intrahepatic, and posthepatic causes of portal hypertension. Prehepatic causes would include portal vein thrombosis, so a big clot in the portal vein. Intrahepatic causes of portal hypertension include cirrhosis, also schistosomiasis, parenchymal disease of the liver, and granulomatous disease. And then posthepatic causes would be right-sided heart failure with blood backing up into the liver, thrombosis of the hepatic vein, and also Budd-Chiari syndrome. So take a look in the study guide and let's talk about Budd-Chiari syndrome for just a second. Budd-Chiari is thrombosis and occlusion of either the hepatic vein or the intrahepatic portion of the inferior vena cava, and it presents with the following signs and symptoms. The most common finding is ascites. Hepatomegaly is almost as common, and these patients also have jaundice. So if they give you a patient with that triad of ascites, hepatomegaly, and jaundice, think about Budd-Chiari syndrome. The acute presentation is going to be acute right upper quadrant pain and hepatomegaly and the rapid development of jaundice and ascites. I want you to circle ascites. That's a big clue. Lots of things can cause ascites, but with Budd-Chiari, you almost always have ascites. Or the patient may have more of a subacute or chronic presentation with a gradual development of ascites and some lower extremity edema and cirrhosis and portal hypertension that all develop over a few months. And eventually these patients will develop liver failure and hepatic encephalopathy. Now, you may also want to jot this down in the study guide. The best initial diagnostic test for Budd-Chiari syndrome is ultrasound, which is going to allow you to see the thrombi. Then the gold standard test to do is a hepatic venography. That's the most sensitive, most specific test that we have. And then for treatment, you can treat with thrombolytics to dissolve the clot, or you can treat with diuretics and anticoagulation. And sometimes we do angioplasty to open up that thrombosed vein, or we do shunting to allow the blood to bypass the thrombosis. Again, Budd-Chiari syndrome is one potential cause of portal hypertension, but overall, it's much more common to see portal hypertension due to cirrhosis. Now, one of the main things that portal hypertension will cause, regardless of the etiology, is varices, or portosystemic anastomoses. These anastomoses are where the portal venous system joins up with the systemic venous circulation, so that when blood backs up into the portal system because of cirrhosis or whatever, that blood can eventually bypass the liver and find its way back into the systemic circulation. So that's why these patients get varices. They can get esophageal varices, hemorrhoids, caput medusae, renal varices, and retroperitoneal paravertebral varices. These are all areas where you have these varices and dilation. Now, because these patients commonly have ascites, we often end up doing a paracentesis. Usually when you do a paracentesis, you need to calculate the serum ascites albumin gradient, which we call the SAG. So take a look at number 6 in the study guide, and let's talk through the SAG. So you've measured the serum albumin level as part of the standard liver panel, and you do a paracentesis, and you measure the albumin and the ascites. And then the serum ascites albumin gradient is just the serum albumin minus the ascites albumin. Now, it's not a ratio, so you're not dividing. It's a gradient, so you're just going to subtract them. And if you have trouble remembering which one to subtract from which, remember it's the SAG, the serum ascites albumin gradient. So serum albumin comes first, then you subtract the ascites albumin from that. So serum albumin minus ascites albumin. Now, if the SAG is greater than or equal to 1.1, that indicates portal hypertension from various causes: cirrhosis, alcoholic hepatitis, heart failure, constrictive pericarditis, massive hepatic metastases, and Budd-Chiari syndrome. If the SAG is less than 1.1, that means the ascites is not due to portal hypertension. Either you have high albumin in the ascites from peritoneal carcinomatosis, for instance, ovarian cancer often causes ascites, or from TB or pancreatitis, or you could have a low serum albumin from something like nephrotic syndrome. Now, what if you do the paracentesis and the ascites has high albumin and high LDH? Well, that suggests cancer as a cause of the ascites. That's something you want to know as well. And what would be your next step in that situation? Well, you need to do a workup for cancer, CT scans, maybe a colonoscopy if that's overdue, maybe a pap smear, whatever the case may be. Now, one other lab test you might run on the ascites is a cell count, because elevated white cells in the ascites could be a sign of spontaneous bacterial peritonitis, or SBP. Spontaneous bacterial peritonitis is probably the most feared complication of ascites. If you have a patient with pre-existing ascites, that ascites fluid is a great culture medium. And if the patient gets a systemic infection that introduces bacteria into that culture medium, they're going to grow like crazy and cause a lot of problems. So with SBP, the paracentesis is going to show elevated white blood cell counts, especially neutrophils. It's also going to show high protein, low glucose, and the LDH is going to be higher in the ascites than it is in the serum. So those are hallmarks of SBP. So anybody that comes in with ascites, especially if they have a fever, you need to rule out spontaneous bacterial peritonitis. Number 7 in the study guide talks about the treatment for SBP. The first blank is cefotaxime. So you're going to give cefotaxime or ceftriaxone or another third-generation cephalosporin for at least 5 days to cover for enteric bacteria and also staph and strep. The next bullet is albumin. So IV albumin will help maintain the plasma volume and preserve renal function and reduce renal impairment and mortality. So that's also important in the treatment of spontaneous bacterial peritonitis. Now, what about treatments for portal hypertension in general? Not just for SBP, but for portal hypertension in general. First of all, there's salt restriction and diuretics. So you don't want these patients to retain fluid because it's just going to accumulate in their belly and lead to more ascites. So the diuretics that we commonly use are a combination of spironolactone and furosemide, ideally given together as a single morning dose. That's the preferred method for dosing diuretics and ascites. We treat esophageal varices with beta blockers to reduce the recurrence of bleeding. Specifically, which beta blockers are we talking about? Propranolol or nadolol. If the varices are bleeding, we use vasopressin or sclerotherapy. And then as a last resort, you have the hepatic shunting via laparotomy or the TIPS procedure, which is a transjugular intrahepatic portocaval shunt, TIPS procedure. This is a short-term solution for severe disease. So what does a TIPS procedure do? It's basically going to shunt blood from the portal system into the systemic system by sort of digging a tunnel or a channel through the liver. So that's going to relieve varices basically by allowing blood to bypass the liver. When you do that, you're decreasing blood going into the liver. So whatever filtering capacity your liver had is going to be decreased. So the plus side of hepatic shunting is that you relieve the varices. But the downside of hepatic shunting is it's going to worsen the risk of hepatic encephalopathy because you're decreasing the liver's ability to filter the blood. All that ammonia and those toxins are going to get dumped directly into the systemic circulation and go right to the brain. All right, go ahead and work through the end of session quiz. I'll be right here, minding my own business. All right, first question. What's the treatment for hepatic encephalopathy, lactulose, and possibly rifaximin? Next, what antibiotics can be used to treat SBP? We said cefotaxime or other third-generation cephalosporins. Next, what two diuretics are used in conjunction for the treatment of ascites or portal hypertension? We said furosemide and spironolactone. Next, what are the symptoms of Budd-Chiari syndrome? So there's ascites, jaundice, hepatomegaly, and possibly right upper quadrant pain. All right, that's it for this video. I'll see you next time.